Welcome to the Surgical Assistant Podcast, a podcast crafted by surgical assistants for surgical assistants, where professionalism meets passion. Hello, everyone. We are here today with the Surgical Assistant Podcast. I'm Kelly.
Hi, Kelly.
And
I'm
with
John.
Hey, John. How are you today?
I'm well. Kelly, how about you?
Good. I'm doing good. We are talking today about an interesting subject. It is the H&P. We're talking about that history and physical of the patient that the first assistant needs to know, some pertinent things that we need to know. First, I do want to mention that it is January as of we're recording this. It's now 2025, and we have a conference coming up in April. And I'm going to start giving that a plug with these podcasts that we're doing, the next several that we do over the next few months, and talking about that Association of Surgical Assisting and the NSAA joint conference is coming up in April, and that's in Dallas, Texas this year. We are not sponsored by them. We are both members of ASA, I think. And so we're just plugging that as members of the organization. And we, as you know, if you've been listening to the podcast, we encourage, professional endowment and professional growth, and being part of these organizations helps us along in our career. So that is going to be the weekend between Good Friday and Easter. I'm sorry, not Good Friday and Easter, but it's is it after
The weekend
Easter?
after Yep, it's after
Easter. So that's the 25th. Yeah. So starting April, I think it's the 25th through the 27th, everyone, and that's in Dallas. So go to the website and look that up. And John and I are planning to be there. Just wanted to plug that, John, real quick here at the beginning of the episode, but we're going to jump right in otherwise.
Yep, that sounds good. Definitely make the conference if you can. It's more than just CEUs. I know everybody says, well, I'll go just because I need CEUs, or people use it as a reason to say, oh, well, it's too expensive. But let's face it, if you want to be a professional, you have to spend money, and this is your profession, and you get updates on legislation, you get to network, meet people, you could find a new job. You can make lifelong friends or great professional contacts, or it's just worth going. I think if you've never been, you're doing yourself a disservice by not going.
It is. And it's interesting. You just ticked my memory about something, that it's because one of the things I'm going to bring up today and share with you in this podcast is something that I only know about because I went to a conference. And these aren't things, you get little nuggets in these conferences. I think it was a physician speaker, or I think it was a surgeon speaker that gave out this information at this conference. And I've used it several times. I've shared it with other people and enriched nurse practitioners and PAs that had no idea. And I'm not going to give any spoilers, but we're coming to it. But it's just, you can't put a value on little things that you can gain by going to these conferences and learning. So yeah, we wholeheartedly, and that said, I've said it in the past on other podcasts, I have not been able to attend a conference in the last couple of years. So I'm really excited about this one, and looking forward to jump back in and make plans to get there in Dallas. Yep. And seeing you, John, we don't ever get to see each other. We never get to see each other. And so at these conferences, you get to reconnect with people in person and kind of see people and talk about things. And it's fun. It's a lot of fun. Hey, it's a way more fun to get CEUs that way than sitting at a computer and doing it on a computer. I will say that. It's for me anyways. All right. So everyone, today we're talking about the patient H&P and what the first assistant needs to know. And we're going to try not to get too far deep in the weeds here, because we could go down a lot of rabbit trails. We're going to hit the high points, y'all, and talk about, as the first assistant helping to take care of this patient in surgery, what is pertinent? What are some things that you need to be looking at and that you need to know about the patient? In corroboration with anesthesia, number one, the surgeon and the circulating nurse. So we can all come together and kind of use the knowledge and information that we have on the patient to take the best care of the patient. So let's see, John, do you want to start us off? And we're going to talk about just some general things. I think I talked about general surgery, but just some general things about the patient that we need to know.
Yeah, definitely. I mean, when we talked about doing this podcast, I, like you, felt the same way. We can get really down into the weeds with this. And do we need to? I don't think we do. But at the same time, we're going to do this episode. And if you want us to circle back and revisit it at a deeper level, we can always do that in the future. That's not a problem. But I wondered, because I don't know myself, but I don't know if there's any surgical assistants out there that maybe work closely with a surgeon or a surgical group. I don't know if you're there in the ER with the physician, seeing the patient for a consult or whatever, because that's kind of where a lot of this stuff originates, is their contact either in the office or in the ER when the surgeon's consulted to see them. There's a lot of things that are involved in that, but the history and physical, it's a must. I think it's a must, and I know I'm preaching to the choir when I say this, but you need to read this, or the history and physical. You just need to. If you're operating on that patient, you need to be informed. There's so much pertinent information that's in there, and it's a bone of contention with me. I don't know what our viewers out there, what their experience is. I would love to hear it. If you can put it in the comments. Personally, I'm traveling right now as a surgical assistant, and as a traveler, they do not give me access to Epic. I've had it at one job that I worked in, and that's it. And it's invaluable if you have access to Epic. It really is. A lot of times I'll have to piggyback off the nurse, and I'll ask to read the H&P, and it all depends on your relationship with them, if they're busy or not, if they close out their chart every time. But I think it's an imperative. We need to learn that, because it tells us, we need to read that. It tells us so much pertinent information about the H&P. Yep. But there's a structure to an H&P. I mean, I was taught to do history and physical in one job I had, not as a surgical assistant, and there's a logical order to that. There's review of systems. There's a lot of things that are in depth, but primarily what we're focusing on is the focused H&P for that surgery. So if somebody comes in the ER with abdominal pain, there's certain things you're going to do, certain tests they're going to get, certain labs they're going to get, and then typically they should have a physical exam as well. Although I find that not a lot of people do the physical exam anymore, but I guess, do you have anything to add to that before I get even
Well,
further? Or
yeah, so right off the bat, I mean, as the first assistant, the primary thing you're gonna ask yourself, some questions. What is this patient's diagnosis? What brings them to surgery today? So we know there are 3 different levels of surgery. There's elective surgery, there's urgent surgery, and there's emergent surgery, right? So, when you're looking at that, we're thinking about, what is their diagnosis? What is the indication for surgery? Why are they coming to this operating room today? That's first and foremost what I mean, the subsequent information now that we're gonna go down and talk about stems from that one thing. Um, we're not are they inpatient or outpatient? We operate on both types of people come from home, through outpatient surgery to be operated on. Sometimes we're operating on people that are in the hospital for a reason, and that's a whole other, you know, more things to look at typically in those inpatients. But, first and foremost, we wanna know what brought them to surgery today. What's wrong with them? What are we fixing? So it can range from minor things, minor elective surgeries, to problematic things, to big things like cancer or systemic issues that a surgical procedure is going to correct. So
Yeah.
I would say that's kind of the first thing you want to know is, what is their diagnosis? Why are we operating on them today? That's going to answer some of your questions right there. And while we're talking about that, John and I both talked about how we know that as the first assistant, we're doing a lot of different things. You're doing a lot of different things, and priority is to pay attention to the room and get the room ready and all that and help your team out. But we both agree that laying your eyes on the patient and talking to the patient when you go to introduce them is kind of integral in kind of doing your own little quick assessment. And honestly, guys, I can go in the name of introducing myself to a patient, and I'm going to interject here too, that just going in and making eye contact with your patient and smiling at them and introducing yourself goes such a long way in helping that patient, their confidence, and it helps them feel better that you know, the nurse comes in and they've got a lot of information that they need to do, and a lot of they're starting IVs and asking all this, and they're in that computer, right? Answering all those questions in the computer. I come in and I don't have a agenda. My only agenda, as far as they're concerned, is to say, "Hey, my name is Kelly. I am a first assistant here, and I'm gonna be helping your surgeon with your surgery today, and I wanted to come in and introduce myself." And just smiling. I have had so many patients say, "Oh my gosh, you're it makes me feel so much better that you came in here and did that." And so, at the same time, you know what I'm doing, John? What are we thinking about? I'm looking at their physical. I'm just doing a quick head to toe assessment of them. I'm looking at what is their affect? Can they speak to me? Can they hear me? Can they understand what I'm saying? Do they have a loved one with them or a family member or whoever? Do they have a support person with them? You're kind of going down through all these things. So I want to know their their baseline abilities. It's gonna help me if especially if we're doing a, well, let's see, like a carotid endarterectomy, for example, because then I'm assessing their neurostatus. So you kinda be thinking about all these things when you're just and I'm literally, y'all, a quick 3, 4 minutes I'm in the room. I make it quick and just kinda getting that baseline, right? Um, Now, if it is, you can be more intentional. If it's a neurostatus thing that you're gonna wanna know that postoperative neurostatus, I will ask them to shake my hand, squeeze my hand, and kinda go through that. Just I mean, literally, guys, 30 seconds. It doesn't take long. My point of saying all that is when you can and if you are able, go do that and introduce yourself to your patient and just do that quick, visual assessment for yourself real quick.
I agree. That's so important. And it helps to allay their fears as well, because I always try and
Mhm,
put myself in the patient's position like I don't know anything about surgery. And they're meeting
mhm.
a lot of people. I know when they come in the OR room into the actual operating room, I introduce myself because that's usually the time when I see them. I don't go to the pre-op area with the nurse or before ahead of time, because it's not the way they do it at the hospital I'm currently at. So a
Right.
lot of it's, a when in Rome kind of thing. I've had assignments where the surgical assistant and the nurse go get the patient from pre-op and bring them into the OR, or they go to the floor and bring them down. That's not currently the way I do it, but the first thing I do is I make sure I introduce myself to the patient, tell them my name, what I'm there for, because a lot of people are, "Who are you? What are you doing here?"
Mhm.
Because a lot of time there could be a lot of people in the room depending on the case, but and like you said, just by greeting your patient and talking to them, you can establish a lot of information. Like,
Yes,
not to get
right.
far into the weeds, but when I was taught to do a history and physical, we had to do cranial nerves 2 through 12. There's specific tests that you do for each one of those. Ask them to smile, stick out their tongue, clench their teeth,
Mhm.
things like that. But if you just say, "Hello, I'm John," and they answer you, you could grossly knock out 2 through 12 if they're,
Right.
a normal response like, "Oh, hi, I'm so and so, nice to meet you." And,
Mhm.
they don't slur their words, they don't, their eye doesn't deviate to one side, or, but like you said, getting that pre-op neuro check is so important. Having to squeeze your hand, yeah,
Yeah, and
that's
I'm gonna
invaluable. I
interject there
agree.
too, John, that just
Mhm.
recently there was a situation at work where, called a stroke alert on a patient in PACU, and
Oh,
how important it is that someone that actually spoke to the patient. As the first assistant, I had actually come in and relieved someone else in that patient's case. They were already
oh,
asleep,
okay.
okay? So I
Mm,
did not see them or talk to them before the surgery because I had relieved the
gotcha.
first assistant, but it drives home the point of how you can give information. You might be the one. You might be the only
Mhm,
person that's left after the surgery is over and the patient's in PACU. If they're having a problem, you might be the only person that actually laid eyes on that patient in that in their normal state. So,
mhm.
that's why this is important. I mean, I feel like some people might be thinking, "Well, that's just too much. Like, why do we have to do that? Why do we have to know that?" Every little thing
Right.
you can know about your patient, not every little thing, but there are major things that you can know about your patient, and it might come in helpful. You just don't ever know. So,
I
so
agree.
yeah, that team that was taking care of that patient and calling a stroke alert was really trying to hustle and find people. Did you talk to this person beforehand? Were they
Mm.
coherent? Were they with it? Were they answering appropriately questions? And so it, that's just one example of why that is important to do that.
Yeah, I totally agree with you.
Yeah.
And that's the first thing I do after I, get everything set up in the room. If I have time, I immediately turn my attention to the H&P and I bring that up. And the first thing I
Hmm.
read is the HPI, or the history of present illness.
Right.
and that's
Mhm.
gonna give you a brief narrative of why the patient's here.
What brought them
And,
in,
from
yeah, mhm,
there exactly. From there, I go down and I do they do a review of systems, and I read
mhm,
that. So if they're there for a bowel obstruction, then I'll pay close attention to what his abdominal findings were. Then
right,
I'll look at this whatever imaging results they have to see. I'll read the report first, and then I'll try and correlate that. I'll bring up the images, and I'll try and correlate that with what I see. But
mm,
that's usually the first thing I start is the history of present illness, and I'll tell you, a lot of times, I'll catch things that is not on the OR schedule.
right,
Like could be an added procedure or something else we might need. So I think it's
mhm,
invaluable for people to read the H&P, and I'd like to hear from everybody what they do in their practice. Do they typically read the H&P before surgery? I bet a lot of us do. I
yeah,
think it's just an excellent habit to get into, and you could learn a lot too by just reading those. I learned a lot early on. I just read tons of H&Ps.
mhm. Well, a thorough
So,
H&P is gonna obviously I mean, if you've got that right there in front of you, that's gonna give you the majority of information. Well, really, kinda all the information
yep.
that you need that you need. The problem comes when there's
Mhm.
not an H&P in the chart, or it's not
Yeah, true.
maybe there's not a current or there's not a thorough H&P. I mean, for whatever reason, that just happens. The
Oh,
nurse
yeah, a
will
lot of
say
times the only thing you could find is the addendum to the H&P where it says, "I reviewed it and there's no changes since the last
right,
H&P." That does me
exactly.
no good whatsoever, you know?
None, 0. So, then I might confer with my nurse and say,
Mhm,
"Is there anything else is there anything I need to know about this patient? Do you have any information to share with me?" Some of my favorite circulators are very free, and I don't
mhm.
have to ask them. They will kinda give me a report of the patient, um,
Oh,
and
that's
I
good.
always appreciate that when they are
Mhm,
forthright and just share that information with me. Yeah, asking the nurse anything that you need to know is certainly acceptable and normal, and really you should be doing. Ideally, we have access to get into I can log into the computer, and as the first assistant, I can look up that patient, click on them, and look these things up myself. Some facilities don't allow us to do that. Um, my current facility, for whatever reason, changed their policy on that, and I can't even go in,
mm,
as a view only status. I can't go in and read the patient's chart. So I do have to depend on the
mm,
nurse to either let me in the chart and read it myself, or she's gonna, he or she, we're gonna review it together and look at those things. But yeah, that's the first thing I look at is the patient, the history of present illness,
mhm,
and look at that, what the surgeon's findings were, why they're here, why we're
mhm,
operating, what exactly we're doing. And a lot of times that will depending on what I read there, will prompt questions in my mind about the actual case, and so then I
mhm.
can go and clarify some things with the surgeon if I need to. So that's helpful. Now, when we're
Yep,
looking
that's a
at
good one.
the specific surgical history. Why would
Mhm.
we wanna know what surgeries they've had in the past, John? That's one I always
Oh,
try to
that's a
look at.
great
I look
question.
Yeah.
Yeah, especially if you're doing an abdominal procedure and they've had abdominal surgery, you wanna know that. I know if it's a laparoscopic procedure and they've had previous open abdominal surgery or a
Mhm,
hysterectomy or a C-section, I wanna know that because, it's gonna influence how we get into the abdomen a lot of times.
mhm,
Maybe the surgeon usually uses a Varus technique, but maybe they had a high peck or something done before that, and
mhm,
it's gonna be a disaster in there, so maybe he would wanna switch to a different type of technique. Maybe he wants to and, go in with an end of with a scope and a trocar, or maybe he wants to do a Hassan technique
mhm.
first. It's gonna
Right, that's
influence where
and
we put our trocars.
mm,
A lot of times I wanna know, especially if the patient is a status post gastric bypass patient, because a lot of times I'll see anesthesia just shove an OG tube down there or an NG tube down, and you don't wanna do that in a vascular or excuse me, in a gastric bypass patient. You
a good
don't wanna
point.
just shove an NG tube down there
Mhm,
willy-nilly. If you have a chance to if they need one down, then I would say wait until you get in the belly to do it because it's such a small pouch and easily ruptured.
mhm,
Um, but there's a lot of different reasons why you don't wanna do that, so
right,
it
and it's
helps to know.
yeah, right, and you said it at the beginning of that, especially in abdominal surgeries, this is a big one. The previous surgery, the surgical history is a really big deal when we're doing any kind of abdominal surgery, right? For reasons you mentioned, it lets us anticipate adhesions. I mean, there's a high likelihood that they're going to have a higher likelihood that they're going to have adhesions. And so that's going to help us to know what equipment, again, just going back to what equipment we're going to need Might he need those laparoscopic scissors to begin with? If we're doing a robotic case, will he need to take down some adhesions first before we can even get the robot in? And I mean, we've all been in those cases where you go in and like, where are we going to put trocars, dude? There's no clear space on the abdominal wall. Like, we got to take some of this down. And are they going to need the scissors? Are they going to need a ligature? What device is your surgeon like? So many things and factors come in here, and we want to keep that patient safe for sure. One thing also that kind of goes along with that gastric bypass history is alterations, which goes along with the gastric bypass, right? Because we're going in there and things aren't necessarily where they're supposed to be. I did a gallbladder one time with a surgeon, and he was doing it laparoscopic. This was before the robot. I mean, or they weren't doing robots at this facility. It's really only been about 5 or 6 years ago. Oh, it's been longer than that. Sorry, about 7 years ago. But they just weren't, the general surgeons weren't doing robots at this hospital. So it was a laparoscopic gallbladder, and nothing looked like it should on that patient. Like it was, things were so distorted and not right. And it turns out that after 3 or 4 hours of trying to get this gallbladder out laparoscopically, he just ended up opening her, nothing, her gallbladder where it wasn't where it should have been, her stomach, her intestines, everything. But she had a Roux-en-Y and then like some modification of it. I am not smart enough to say all the modifications she had, but she had modifications. And so her anatomy was not textbook, to say the least. So these are some things that if I had seen that and known that, you can anticipate. Anticipation is a really big deal. So, I will say that. So adhesions, altered anatomy, those kind of things, and surgical history.
Oh, you brought up a good point, because this happened to me on Friday, as a matter of fact. This is Sunday when we're recording this, and that case I had Friday was an emergency add-on. It wasn't,
Mhm.
true in extremis emergency, but it was a gallbladder that we were taking out, cholecystectomy. But the patient had a vertical gastrectomy, vertical sleeve gastrectomy
Right.
prior. So what that tells me then, the reason we're doing this is for choledocholithiasis. The patient's, labs are all elevated. They had a little scleral icterus. So you can see that, they were getting a little jaundice from the obstructing stone. But
Mhm.
why would a vertical sleeve, be a factor in that versus a gastric bypass patient? If that patient is a gastric bypass patient, they're coming in for a gallbladder, they can't have an ERCP because there's
Oh,
no
yeah.
access to that remnant stomach
Right.
through your typical,
Uh-huh.
upper GI that you would normally do. But if they
Mhm.
had a vertical sleeve gastrectomy, well, that's just fine. All you're doing is make the stomach smaller. You can get through the pylorus into the ampulla, and you can get
Right.
into your pancreatic ducts. You can get to all your ducts from the
From that
stomach. Now,
that route,
there
yeah.
there is a way they can do it. I mean, they do where they put the scope into the stomach, and then, or they put the scope in through a port and then make an enterotomy or a gastrotomy into the remnant
Right.
stomach and then go in that way. But that's a much bigger deal, much involved. And that's more, I think, at tertiary referral centers. I haven't seen that done in any of the rural hospitals or community
Right.
hospitals that I work with. But that you need to know, because let's say that patient had a gastric bypass, and sure enough, there was a stone, in the common bile duct that was keeping it from draining into the small intestine, then we need to
Mhm.
fix that right then and there. That means we need to do, maybe a choledocoscopy, or we need to do something right then and there with the common bile duct. We have to
Mhm.
explore it, whether that's opening the patient and doing it open, or whether it's doing it laparoscopically with a choledocoscope. I put that in before through a trocar.
Mhm.
We've done them that way. So that's an important piece of information to
Yeah.
know, because you
That's a
can't leave a
good.
stone obstructing, you
Right.
know, you
Yeah.
have to relieve that obstruction, so
Yep.
that's one
Yep.
reason. So, that's just a little
Yeah, so
dovetail with
all
what you
these
said.
things, all these things can affect so many aspects of what we're looking at and what we can anticipate. I wanna talk about medicines that the patient's on. I mean, just as the first assistant, we're talking about intraoperatively. I always want to think about risk factors that our patient has, and so medicines that patients take play a huge role in what we can, anticipate during surgery, whether it's increased bleeding. I know medicines like if they're on chronic prednisone therapy, or, you know, even certain things, if they're inpatient in the hospital, what are they being treated? What medicines are they on? Obviously, any kind of blood thinners or, medicines like that are going to affect what we're doing and things that we can look at happening. Um, but healing issues too, when we're talking about closing the wound, if we're the ones left closing the wound, and when we're trying to decide sutures to use, or, it's easy for us to say, well, I just use what the surgeon tells me to use. But guys, we need to know things
Mhm.
that affect healing because surgeons are busy. Surgeons are busy and they're human, and they're not always going to think about every little tiny aspect. So if for instance, your patient, I'll give a good example. Things like conditions like rheumatoid arthritis, for example, psoriasis, psoriatic arthritis, Crohn's disease. They have all these new medicines now, these biologic medicines that patient can be on, and they will inhibit, they put a patient at increased risk for infection, number one. So, you can take all these factors in and say, well, do I need to use this suture versus this suture? Do I need to use, and then depending on the procedure that you've done. And again, John and I have been doing this a long time. I by no means know everything, but because of the different areas of specialties, I'm sorry, that I've worked in, I just have little bits and tidbits of
Oh, yeah, I completely agree, and another reason why, reading the H&P is so important is if for things like that, to see if they are, number 1, diabetic. Are they
Mhm,
on any immune modulators? Because, like you said,
mhm,
it'll affect on how we close the incision. Like, I may wanna use monofilaments for that to
correct.
not give bacteria a place to harbor, even if,
Mhm,
it's a primary closure, and I may wanna put Pernio on it, which I may normally not do, but I like the
right.
antimicrobial effect that it has.
Mhm,
Afterwards, I think it's up to 72 hours afterwards, you have an antimicrobial effect, plus it gives it that extra strength of
mhm,
holding the wound edges together, so I may add to do opt for something like that. If they have some kind of bleeding disorder, I may wanna bring in some extra hemostatics, like maybe Surgiflow or FlowSeal,
yes,
whatever you
yes.
guys have at your place, and sometimes Fibrillar or Snow or any other adjunct that we could use, and the surgeon may wanna give, the blood bank a heads up if we need fresh frozen plasma or if
Mhm.
we need cryoprecipitate or something like that to help, systemically with the patient.
They're on chronic
TXA is
anticoagulant.
an option.
Yeah,
Right, exactly, if they're
that's
on
a very good
chronic.
point that we needed to, and having
Yep.
those hemostatics available in the room, yeah, mhm,
Mhm. If they're on Coumadin, obviously, we wanna know that. Ideally, in the old days, they used to bring them into the hospital, switch them over to heparin, then bring them to
mhm,
surgery because we can reverse heparin. Coumadin, you can't reverse. But
right,
now there's other medications. It's a PCC, which I'm blanking on what that stands for, but medications like Kcentra, when they're on Coumadin, they can have a high INR, you give them Kcentra, and it'll bring it down to
mhm,
1.5 or lower within 30 to 60 minutes,
mhm,
and it gives you a window to operate on. So it's great for those kind of patients. But yeah, any kind of weird disorders that they may, well, not weird, but unusual disorders they may have.
mhm,
And it just gives me a heads up to bring things in because inevitably the nurse is going to be out of the room getting something. It's just the
right,
nature of surgery.
exactly,
We need
mhm,
something right now, and the nurse went out to get something we had previously asked for. I try to limit the nurse leaving the
yes,
room as much as possible. So I try to get all that stuff in the room. Like you had said, if they've had previous abdominal surgery, maybe I know the surgeon likes to use the Maryland XP ligature. So I'll bring that in the
mhm,
room and have that available just in case, or, whatever they like a harmonic instead, I'll bring that. So it's just,
yeah.
if you're not reading the H&P, I don't want to sound authoritarian, but if you're not reading the H&P, you're wrong. You need to read the H&P.
Right, and we're talking in depth about this, but this doesn't take long to do. I mean, you can have a quick, and
Exactly.
the more H&Ps you read, the more quickly you
Hmm.
can kinda go through and kinda mentally hit those high spots, like previous surgeries, history of present illness, then you go previous surgeries, meds, systemic, like, do they have any systemic issues, disorders, like you just said. So, you're kinda just checking down. I mean, it takes a couple of minutes to do at the most, just to kinda get an idea and and then again,
Hmm.
asking your nurse, "Are there any concerns with bleeding? Do we have the hemostatics we need? Do you wanna"
Hmm.
we're gonna talk about the vascular patient here in just a minute, and we're gonna get a little bit more in detail with some of those things. Yeah, so the obviously cardiac issues, so you're gonna want
Mhm,
kinda try to be in tune with, that. So while I may not have
mhm,
all of the, uh, skill and education to know the complete ins and outs of these cardiac issues, I wanna know if is anesthesia worried about anything, you
mhm.
know? What's the ASA of the patient? Uh,
True.
what are they gonna be worried about? So I try to stay listening to
Mhm,
anesthesia, even if I'm not engaging with them. I'm listening to if they're having any conversations among themselves about any concerns they have with the patient. Just again, so I can be in that loop and I can be aware of things to watch out for on the field. Just
mhm.
anything you can communicate with them, how you can better help them with induction or extubation. Or are they worried about the patient leaving the room still intubated? Like, are they going to have to keep the patient intubated? Any
Mhm.
lung issues, breathing issues. COPD is a big one. COPD is a big one that we need to be on the lookout for. Just kinda from and that takes us out of the actual intraoperative realm and into the anesthesia realm, but we're there to assist anesthesia as well.
Mhm.
So just kinda knowing those things, just getting the big picture again on the patient and just you'll be way ahead of the game and, um, again, keeping that patient 100% safe in the operating room under our care. I talked about anything to add, immunosuppression, anything to add there? I mean, just kinda know, and if you don't know, don't be afraid to ask questions either. I'm telling y'all,
Mhm.
I have never had a anesthesiologist or a surgeon or a nurse, not like that I was asking a question about a medicine the patient was on or a diagnosis that they had, or I just never
Mhm.
have. I get answers, and this is how we learn. You're not expected to know everything, and as long as I've been doing this, I
Right.
do not know everything, and I try to read and
True.
keep up with things, I don't know
Mhm.
everything, but ask questions if you need to, "Doctor, Smith, why do we need to be concerned about their platelet count in the
Mhm.
surgery?" Whatever it is, just don't be afraid to ask questions. So, I would encourage you there too.
Exactly, and I always think of and now, I mean, like I said, I'm traveling currently, so I don't get access to Epic where I am, but I usually ask the nurse, "Hey, look, when you're done with all your stuff, do you mind if I just quickly look over the H&P?" Or especially in orthopedic cases, I'm like, "Hey, when you're done with the chart, is it okay if I look at the X-rays really quick?" It helps me to get an idea of yeah, it's a fractured wrist, but what kind of fracture is it, you know? There's other things too. If it's if we're doing a fractured hip, is it what type of fracture is it? Because the way we fix those is different. Intertroch versus subtroch versus, a subcapital fracture. I mean, they're all handled differently now. Now, one thing I'm seeing, which is new to me, usually for a subcapital fracture, I'm used to doing cannulated screws, 3 cannulated screws in a triangle pattern. Now it's the Synthes FNS system, the femoral neck system. I have yet to see one like that, but it's more like a dynamic hip screw in that respect, sort of. But so, it always helps to look at that stuff. But I keep in mind, and these days with H&Ps, they're all dictated in the computer, so it's so easy to read them. I hate to say, but back in my day was when they were all handwritten, and if I couldn't read the handwriting of the surgery, I was SOL, or the handwriting of the surgeon. So I would just, nowadays it's so easy to do. Right, but I always keep in my head that sample history that I remember from when I was an EMT, signs and symptoms, allergies, medications, past medical history, last oral intake, and events. Well, that's not really events leading up to 911, but, what made them call 911, but that's not important in this situation. But I definitely wanna know when they last ate, what allergies they have, what medications they're on. So, just a good idea to read the H&P and talk with the surgeon. If the H&P is not in there, I go find the surgeon and say, "Hey, what can you tell me about this patient?" I don't and they'll give you a brief rundown. They usually have no problem explaining it. But it was funny because that case I mentioned on Friday with the gallbladder, immediately after that, we did an appendectomy, and I asked the surgeon, I said, "Let me ask you a question. When the ER calls you about these patients, what do they tell you? Do they tell you, they give you a rundown of the physical examination they did?" And he chuckled a little bit. He goes, "Oh, no. They just call me up and read the CT scan report that says they have an appendectomy," which is like the diagnosis machine, as a lot of residents call it. But,
Just call it an appendicitis, and it's not and they're just going off the imaging. They don't
exactly.
do
I
the
read all these H&Ps, and I never, ever read in a ER physician's dictated report where it says positive Rovsing sign or positive for rebound tenderness or positive for obturator sign, or those are all
Hmm.
physical signs for appendicitis, if you don't know.
Right. Classic.
So,
I mean,
and
it's
there's a different
classic.
test, right?
You know,
Mhm. And
it's
Rovsing's is
crazy.
one that I've always liked because it's when you push on the patient's left side, they have
Mhm.
pain on the right side. That's a
Mhm.
Rovsing sign, and it can be
Yeah.
present or not present, you
Right.
know? And
But it's just
the
an
appendix is
assessment
the great
tool.
masquerader.
Yeah.
Right, exactly. So it's one more thing, if they have guarding rebound tenderness and then they have a Rovsing sign and they tell you, "Oh, well, when did the pain start? A couple of days ago. It started around my belly button. Now it's kind of in my, right lower quadrant." But we're not going into physical exams here because that's,
Right.
that's not what we do. Like I said, we don't know everything. So if you're at a place where you do physical exams, please let us know in the comments. But
Oh, yeah.
but
And first
so that's
assistants
just to kind
do,
of,
they do.
yeah, I'm sure some do.
So,
Yeah,
I like to mention that because that is the role of some first assistants depending on where you work and what role you're in. So,
exactly.
yeah,
And
obviously,
age
anything
is
to
a
add.
factor.
Yeah, age, yes, and I'm sorry, I'm glad you said that, John, because I did age and, body habitus also.
Age, body
You know,
habitus, great.
weight,
Gender, that's
where
another
is that
one. Yep.
weight? Do we have folds of skin? Do we have, you know yeah, absolutely, those things do play into it. Age definitely
Hmm.
plays into the immune system, and, we know that older
Hmm.
people have a lower immune system. They're immunocompromised, as well as younger, if
Right.
you're operating on pediatric patients.
Right.
So, yeah, all those things, body habitus, nutritional status,
Yep.
all
Nutritional
that those
status.
things, play into
Comorbidities,
the
and like you mentioned, medications, but
mhm,
comorbididities are definitely
and at the
something you
end of
wanna
the
be
day, for
aware of.
us, that directly correlates with, intraoperative bleeding and
Mhm,
healing, and so for the first assistant, I feel like those might be the 2 most important things, especially the healing issue because if we can make a call on what we're using to close, and yeah, I know the surgeon normally uses
mhm,
Vicryl, but let me go ahead and use that monocryl instead because
mhm.
of these factors that you know about, it's just it's gonna help. It's gonna be helpful to know those things.
I
And a
agree.
lot of times if the surgeon's standing there, I'll ask him, I'll say, "Can I use, since this,
Mhm,
this, and this, since A, B, and C about the patient, can I use monocryl instead of Vicryl? Do you mind if I do that?" And a lot of times,
mhm.
I gotta tell you, they're appreciative that you paid attention and you're thinking about that. So, um, again, it doesn't hurt to ask.
Yep,
And if they're not in the room, it is within your scope. And if you're comfortable, you can make that judgment call. And I always, if I do
yep.
something different than that's outside of the normal routine of the surgeon, I make it a point to find him after that surgery and tell
Yes,
him that I did it different because he's dictating that operative report and he needs to know. So we want to that
right.
as well, that it is important to communicate to your surgeon if you do something outside of what is his or her normal routine. So,
Yep, I agree, and I can't emphasize that enough. That's a good point, Kelly. I do that as well. If you do something that's out of the ordinary that you normally do with a surgeon, tell them. You don't want them
mhm,
blindsided when they take the
mhm.
dressing off, or you don't want them seeing them on the floor the next day and like, "Why does this patient have a PICO,
Oh my good yeah,
negative
right.
pressure wound dressing on? Why? Why? I never
Mhm,
do that. Why is that on this
mhm,
patient?" You don't
mhm,
want the patient asking the doctor, "Hey, why do I have this vacuum thing on my
mhm.
knee?" And the doctor's like, fuck, I don't know."
Right,
Pardon
right.
my language. I'll
Yeah,
take that out, but
right.
yeah, I think I'll edit that out. But yeah, exactly. So that's the first thing I do is I update the surgeon right away.
Yeah.
If he's in 2 rooms, I go to the room he's in and I tell him, "Hey, on that last lady, I put a Pico on for this reason, or I didn't put a Pico on for this reason, or
And be
whatever." But
prepared for them not to like
right,
it. Be prepared for them to say, "Why'd you do that?" No, I mean, I'm not kidding. You gotta be able to stand your ground, give a rational reason.
that's true.
Obviously, if there is a real question about it like for a Pico or a, Vena in the operating room simply because of the cost of those items, I would
That's
and
true.
I felt strongly if I felt strongly that the patient needed it and was gonna benefit from it, I would probably have the nurse call the surgeon and ask, "Can I use that?" But yeah, be prepared for the surgeon to say, "Well, don't do that again." And you gotta say, "Okay, I
Mm,
won't, but I'm giving him a solid rationale to why I did it,
right.
and
Yep.
you don't ever have to do it again, if they don't really love that you did it or change something. But,
But
you
honestly, I think I've had surgeons say this to me is, "I appreciate you doing that because they know you're thinking and
more
you're
often
looking
than
out for the
not
patient
more
and you're
often than not.
engaged."
Mhm.
Right. It's not just
Yeah,
an assembly line that you do everything the same way. You're taking each patient individually with their
individually.
own body habitus. Well, body habitus is a great reason right there. Let's say the patient has a huge pannus and you're doing a total hip in a direct anterior approach. Well,
Yeah.
you don't want that flopping over the
Oh,
incision or
no.
bacteria,
Mm-mm.
fungus, everything grows in that skin
Lots.
fold.
Very
So,
common site for
um,
postoperative infections, those groin and inguinal areas. Yeah. Mhm.
exactly. Or if you do a C-section and the patient has a huge pannus,
Mhm.
I always put a pico on those patients. I've never had a surgeon chastise me for doing that. But
Right.
but you're right. Even if they don't want you to do it, they're still appreciative that
Even
you
if they're
did it
not thrilled,
and
yeah.
you're thinking about it. And they may
Uh-huh.
say, "Hey, that's great, but call me next time before you
Y
do that." And then you
exactly,
may
and just be
have the nurse call,
yep.
right, and you have to rationalize, you have to make your case right then and there for it. But
Mhm.
9 times out of 10, stuff like that, they're not gonna fight you on.
Right.
But
That's
yeah, that's a
true.
good point that you bring up.
Our point is think about it. Think
Yes.
about what you're doing and why you're doing it, and think about factors that affect what you're doing and why you're doing it. That's really
Yes,
the whole
and
point,
always
isn't
tell
it?
the surgeon.
'Cause
Yep,
the whole
always
point is
tell the
the
surgeon.
factors here, the patient factors, the individual patient factors that affect why we're doing what we're doing, how we're doing what we're doing, and, making those clinical decisions on the spot sometimes, and knowing this patient history is going to, uh, be so important to know. I did wanna talk now
True.
vascular and endovascular is, is my wheelhouse. I love
Mhm,
I won't call myself an expert because 'cause it's been some time since I solely worked in vascular and did vascular,
mhm,
but I love it. I love vascular and endovascular surgery, so I just wanted to
mhm,
address, things there with that, and that's we know that we're gonna be using heparin, in a lot these cases,
mhm,
we're gonna get it systemically, and so we wanna look at that patient specifically on their labs. We want to look at and let's just talk about labs in general too also, because we haven't really talked
great
about
idea.
some of the labs. So we'll go back to the general patient and some of the main highlight labs we're looking at is just really the basic CBC, the H&H, right? We wanna know that
Mhm,
hemoglobin and hematocrit, their basic CBC.
BNP.
Uh-huh. Yeah, their BMP and yeah, because we wanna know their sodium and
Mhm,
those kind of things
and
are
their
important.
liver enzymes if it's a
Liver enzymes.
gallbladder,
Mhm,
pancreas, stuff
mhm.
like that, so, yeah,
Oh,
and definitely
okay.
if it's a female patient, the beta HCG, we definitely wanna know
Yes,
that.
and I had that written down to talk about too. So, yeah, pay attention to your
Excellent.
childbearing, potential for your females,
Mhm,
and they always need that HCG, and if you have to be the 5th one to ask, 6th one down the line to say, "Do we have an HCG?" Just say it because that's very important. You'll hear the nurse and the anesthesia talking about all that too, but that's a big one. Definitely those the CBC. Now, if it's a patient that,
mhm,
say, is like, maybe in critical condition and coming and maybe they're being perfused with blood already, but maybe they're not. Maybe they have a low H&H, and we're really
mhm,
anticipating the fact that we might have to give them blood intraoperatively. Or if it's any patient that you think is gonna lose blood, maybe their H&H is kind of on the borderline, uh, that type and screen is important, but beyond that, that type
mhm.
and cross. I mean, if you
Yes.
so the type and screen has gotta be done to on I don't know, it seems like these days, John, they're not doing it on everybody. Have you found that? They're not doing type and screens on
Right.
100% of these patients.
True, unless they think
Used
they're
to,
gonna
they
need blood, you're
did.
right.
I but have had patients I've had lots of patients, and I've noticed it in the last few years where they come to the
Mhm.
operating room and they don't have a typing screen, and I'm like, "What? When did they start doing that?" So I'm not on that
Oh,
end of
wow.
things these days, and I don't know
Right.
what that has changed, if I guess that's not part of a basic preoperative lab requirement anymore. But anyways, you definitely wanna make sure that your
Mm,
patient has a typing screen. If you have any indication at all that they're going
mhm.
to need blood. Type and cross is the one that's more specific to tell us what, they're getting packed red blood cells, or I guess any blood product, type and cross. Am I right about that? If they get any blood product, they need to type and cross, don't they?
Type and cross, and that's important. In a lot of hospitals, it's only good for a certain amount of time. So, if
Right,
they've had a type and
right,
cross and it's outside that, then they gotta get another type and cross before they send down cross-match blood. That's
right. So if
important. In
you're
a trauma setting, it's a little different. They tend to use now they're using low titer whole blood for patients to resuscitate them.
oh,
But
I
yeah,
didn't know that.
that is
Okay.
important. Yeah, I see
I
the
did
trend
not know
going.
that.
That's what it was at the conference this year, and most places are switching over to that.
Okay.
So,
Right.
but
So
we'll talk about that in another conference.
yeah. So those basic labs again. So you're looking at those lab values in the vascular patient, though. We want to focus on that INR
Yes.
and what does that stand for? International
Oh,
something
international normalized
something
ratio.
normalized ratio. I couldn't think what the N was. Like what is the normalized ratio? Yeah. So that's particularly important in the vascular patient. We want to know the
Mm-hmm.
INR for sure before you take a vascular patient back. Creatinine, if it's an endovascular case where we're going to be
Mm-hmm.
administering contrast dye, we want to know what their creatinine is. A lot of those patients are dialysis
Great.
and kidney failure anyways.
Mm-hmm.
Um, but IV contrast is cleared through the kidneys and the kidney function really is important there. So if their creatinine is too high, you can't do I think typically it's over 2.0 or 2 something. If it's higher than that, try to get that corrected before doing an endovascular case or do CO2
Right.
contrast, which that's a good option to do and not use IV contrast. So,
Okay.
I think those are the 2 most important ones I could think of for the vascular and endovascular, patients there.
For sure. Yeah.
I will
And lab
say along
values.
Go ahead.
No, what were you going to say?
I was gonna I did wanna mention real quick, kinda knowing the, one important one for vascular patients, endovascular, getting contrast, is knowing that there are contraindications. So metformin, particularly, metformin is a
Mm-hmm.
common PO medicine for diabetics, and there is a, interaction with IV contrast because metformin is, excreted by the kidneys,
Okay.
and we know that, like I just mentioned, IV contrast is cleared in the kidneys, and
Mm-hmm.
that's a contraindication. If a patient takes metformin and has not been off of it, that can be a very
Mm-hmm.
potential contraindication to them having an endovascular procedure until
Okay.
they've been off metformin. Ask me how I know this. I mean, this happened when I
Oh,
worked. I had a patient that had a bad they get actually go into metabolic acidosis.
oh, okay.
It's not common, but it can happen. I've seen it happen. The patient when it had delirium, confusion,
Oh,
disorientation
interesting.
because they were on metformin and we did an endovascular case on them and not even the surgeon didn't catch it. So,
Mm.
you it's easy to hear John and I talk about things and say, you really need to look at this. We both have experience behind us and sometimes it's those mistakes that we make or things that we miss in our history of doing this for however many years that makes us like that. Like, oh, I'm going to pay attention to see if does this patient take metformin because I never wanted that to happen
Mm-hmm.
again, and that happened to our patient. And I'm the one that's clearing that patient for surgery and doing their pre-op check and going over their meds and going over all these things and then going and doing the procedure with them. And we missed that. And this older gentleman, he was up in age, so again
Mm-hmm.
compromised with his systemic
Mm-hmm.
function, but he was on metformin. We did the endovascular case and he became combative. He was
Mm.
disoriented. He was confused and he was not like that baseline. Yes, he was older, but he was
Mm-hmm.
well with it, like, alert and oriented times 4
Right.
all the way, times 3, whatever. And I sound like a dummy. I said times 4, whatever it is. He was normal and yeah, and it took a couple of days for him to get over that. That was really scary, and we
Okay.
were trying to figure out
Mm.
what happened, what was wrong, and again, even the surgeon missed it. So, I have never forgotten that they're so kinda knowing general contraindications with certain meds that the patient might be on and anything you might be administering during the surgery is another thing, and if that one tip can help somebody kinda know that and
Mm-hmm.
say, "I'm gonna start looking at that from now on," I wanted to mention it. Yeah.
That's great. Yeah, and that's an excellent example, Kelly. And when it comes to labs, I think it's important to know normal lab values for the major things that people are concerned about that come to surgery. What your normal sodium level is, what the range of normal is for sodium, potassium, calcium, all the electrolytes that we need to know, what normal INR is, what a typically normal H and H is, or the pertinent abnormalities, what we need to be aware of. So, because a lot of times, they'll do the BNP, they'll do the CBC, and we want to know those. We want to know what the liver functions, the liver function test is, because that gives an indication of what the liver is. So if it's a gallbladder patient, we're going to focus on those. And a lot of these have to do with focused HNPs. We're not talking a systemic patient that comes in through the ER where you're trying to whittle down and decide what they have. We already know by the time they're coming to surgery what they have. So then we can do a focused abdominal exam. We can do a focused HNP. So we can do a focused history just on their issue that they're coming to surgery for. So all that stuff is important. And, that your HNP is your gold mine for all kinds of information. It'll help you avoid mistakes. It'll help you get equipment that you need, metabolic stuff that you need for, like hemostatic agents and things like that, medications. It can let you know of possible things you might need, other procedures they need in addition to what's going on. So I think it's an invaluable source of information. And I think that everybody should be reading the HNP. It just familiarizes you with the patient more. I've had it just in simple cases like a breast biopsy where the doctor was looking in one location with the ultrasound and couldn't find the clip. And I said, well, when I read the H&P, it said it was at the 10 o'clock position. So
It's
we looked
happened
at
many
10 o'clock
times to me
position and
too
there it
because I
was.
had just read it, right,
Right.
and we gotta think, they've got all these patients to take care of that
Right.
they're trying to see, and we're focusing on one at a time, the one
Mhm.
that's right in front of us, and that's a great
Yep.
point, John. That's happened to me too, like, "I thought I read such and such, such and such," and they're
Mhm.
like, "Oh, yeah." So, that
Yep.
too.
And that's
I mean,
what he
going
said
back
to
to
me. He
the
goes, no, I think it's, well, hang on. He said, I think it's in the 6 o'clock position. But it
uh
is exactly your point was that was our next patient. So he just got the two patients
Uh-huh,
confused.
uh-huh,
But
and it's easy for them
where
to
there
do,
was no
"Hey."
harm, no foul, right? And but what he
No, but
did
it's
was
a
he didn't take my word for it. He stopped and had the nurse bring up the H&P and P, and he went and
good,
read it. So,
good.
that
Again,
is,
example
I
of
could have kept
why
my
we
mouth
need to
shut and
know.
he would have got there eventually, but it sped
No,
the
that's
surgery up a little more. So
It's a good
I cut
example
you
of
off. What
why
were
we
you going to
need to,
say?
yeah. Well, it's a good example of why we need to know, and why we need to know what they know too.
Hmm.
I just was gonna mention real quick
Exactly.
on that vascular patient, the potassium for, because a lot of those vascular patients, so when you're in the patient, and this,
Hmm.
the main point of what I'm gonna say here is just knowing again those, systemic problems that your patient has. A lot of vascular patients are kidney failure, they're dialysis patients. And they're not gonna, if they haven't had, if it's been 2 days since they had dialysis or a day and a half since they had dialysis, their potassium's gonna be up. So, we've had to treat patients with Kxalate to get that potassium down. Sometimes you have to
Mm.
cancel the surgery until they have dialysis. All these
Yes.
things. I did wanna mention that in relation to the vascular patient because that is important, but the bigger point is knowing the patient's systemic or medical history issues, their systemic, issues, their comorbidities, and how it relates to
Mhm.
the surgery that you're doing. So, you have a responsibility as the first
That's a good
assistant
point.
to know these things, and don't let anybody tell you otherwise. It is your business
Right.
to know. You have just as much right to know these things about the patient as the circulator, anesthesia, and
Oh,
I share
exactly.
information with the scrub tech as well because
Mhm.
I enjoy teaching them, and I like CSTs that I'm working with that like to know as well. It takes a whole team, and you don't ever know when somebody's gonna overlook something or miss something, and because you read what you needed to read, you can step up and say, "Well, I think I read this, can we double check that?" Or, "I think I saw this in their
Mhm.
chart, can we double check that?" Just the other day, I had a patient, this doesn't really have anything to do with reading the H&P, it just has to do with me listening to what's going on with the
Mhm.
patient, and one of the things was we didn't even talk about patient allergies. I think that goes without saying, but obviously we're looking at the
Mhm.
patient allergies. This patient had a true anaphylactic allergy to narcotic medications. So they couldn't get any
Oh, really?
fentanyl. They couldn't get anything
Really?
with going to sleep.
Interesting.
And I had heard the
Hmm.
CRNA talk about it. The nurse talked about it, told me about it. The CRNA knew about it. But the anesthesiologist that was on came in to put the patient asleep, and he was
Mhm.
injecting his syringes, and I had to speak up, I just felt, I had a gut feeling, and it was fine, but I just felt like I needed to speak up
Mhm.
and say, "Now, I'm just confirming that this patient does have an anaphylactic allergy to narcotics, so we're not giving any narcotics, right?" I wanted to speak that because he wasn't in on the room when I was being told that it was a
Right.
severe allergy. And he was, again, very gracious and appreciative that I spoke up. So anything we can know about these patients, whether it's from reading the HMP or listening to
Mhm.
conversations or being given a verbal report from the nurse, it's important. It's very important. So, yeah, we would love to know comments of how you practice this at your facility. If there's anything that we missed that you want to say, please comment and let us know.
Yep, I agree. And, yeah, bringing up allergies, I'm sure that, like me, you've seen a lot of crazy allergies make it onto a patient's chart,
Mhm. Uh-huh.
and I am dead serious when I saw most places, if they have a physical folder that is a chart, they usually put a big sticker on the front that has their allergies on it,
Yeah.
and this one literally said oxygen, and I'm like, I had to ask the patient, I'm
I
like,
know.
"Your chart says you're allergic to oxygen. That's pretty much incompatible with life." I didn't say that to her because she was a nice old lady, but I was like, "How does that happen? How are you allergic to oxygen?" Oh, she goes, "Well, it dries my nose out." They put the nasal cannula in unhumidified and it dried
See,
her nose
I
out. Of
know,
course,
that
but
could be
that's
a
not
whole
an allergy.
John, that could be a whole
And
podcast
that
episode in and of itself. I
well,
mean, we're gonna get
it
off on
could,
a
but I
rabbit
think
trail if we start talking about that, but yeah, you're right.
no, I'm not
But
gonna
that's
talk
so
about that,
funny.
but I'm gonna bring it up that allergies there's so many shibboleths when it comes to allergies, less
That's
most people
true.
think they have a penicillin
Oh, I
allergy and only
know.
30% of patients actually do,
I
so
know.
but I
But
think
then
no,
again,
but
we
I
have
think
to
your
hear
point
we have to look at it
I
and consider it.
yeah, but I think you brought up a valid point. I mean, that's on the patient's allergies, so, of course, it furthers
Right.
more questioning, it warrants
And
further questioning, and then if they are a
mhm.
true allergy, you just did the right thing by letting the anesthesiologist know because he was late to the game, you don't know what he knew or
Yeah, I
didn't
didn't know
know,
what
and
he was aware of. Right,
nobody's gonna
right.
fault you for saying that. I've had people
No.
tell me things I already know, and I just say, "Thank you for telling
And
me.
my
I know that, but
yes.
thank you for telling me."
And my point is
You
in
know?
that again is if you're, just if you're one of those reticent people that you're shy to speak
Mhm.
up, you have a right to speak up. You have a right to, obviously in a tactful, professional manner, speak up and ask questions. And it's good for the
Exactly.
patient, for the team to be all on the same page and have all of the right information.
Exactly, and that's the main takeaway from this, I think it should be for this podcast, is that we are part of the operating room team.
Mhm.
We are integral part of care for that patient, so we have every right to read that H&P
Mhm.
because it
Responsibility, in
keeps us
fact. Yeah.
informed. Right, yeah,
Mhm.
you're I think that you're derelict in your duty if you don't review that,
Mhm. Yeah. And I
I
and
mean, it's the
and
way
I
it
make
is.
that point John, and appreciate the way you make the point because I know for myself, and I would bet a lot of money that you have too heard first assistants say, "I don't need to know that. I don't need to know that. I don't need to know the
Yes.
H&P." And it burns me up to hear a first assistant say that.
Mhm.
Absolutely,
I agree.
you do need to know that. It's your responsibility to know that, and derelict in your duty is a good I couldn't have said that better. It's you need to step
Mm,
up and have and own that responsibility and gather that information and know it for yourself. So, yeah. All
I agree.
right. Well, that's gonna
And
wrap it
there's
up for today, I
one
think.
that's right, it's gonna wrap it up. I wanna bring up one final point,
Okay,
though, or
good.
not one final point, but one suggestion I wanna make, and it's
Okay.
totally up to everybody, but I read a book called Cope's Early Diagnosis of the Acute Abdomen by Zachary Cope. I think it was written in the 30s or 40s, and you make, "Oh, that's dated," but it's not really because it gives a lot of useful information on diagnosis of the acute abdomen without all the modern imaging technologies,
Mhm.
how you can, I just think it's a great book. And one thing that always sticks in my mind from that book, I read it, oh my God, probably 10 years ago or more, but it's seared into my brain when he's talking about perforated gastric ulcers on patients. I remember the line exactly. It says, "To delay on these patients is to invite disaster." And it's totally true. I mean, and the example he gave in the book is most patients die within 12 hours if not being
Mhm.
operated on for a perforated gastric ulcer. That is what you're up against. And,
Right, right.
I see it all the time. These patients are just doing terribly, and then we operate on them and they turn around. I mean, it's
Mhm.
amazing.
Yeah.
I've brought it up before in cases, but I think, it's seared into my mind. So it's just a suggestion. It's a great book.
Yep.
If it's not for you, don't read it. But Cope's Early Diagnosis of the Acute Abdomen.
Yeah.
It's
Okay.
required reading at a lot of medical schools. I just think it's an excellent idea to read that book. So that's just gonna
Awesome.
throw that out there.
Yep.
So,
All right. Good. Good deal.
but
All right, everybody. Well, stay tuned. There are more podcasts to come. We hope you enjoyed this one. Like and subscribe on YouTube if you'd like. And as usual, we invite comments and suggestions
yes,
here
please.
as well. Yep. All right. We'll see you next
Yes,
time.
everyone. Thank you very much, and we'll see you on the next one. Thank you.
Yeah. Bye.
Bye now.
Thanks for listening today. We invite you to like and subscribe to this channel and leave a comment if you'd like. Feel free to look us up on Facebook at the Surgical Assistant Podcast or email us at thesurgicalassistantpodcast@gmail.com. Until next time, content of this podcast is in no way intended for diagnosing or treating surgical conditions. No patient specific information is shared. All HIPAA guidelines will be adhered to.